Let me start recording. Good morning, everybody. Today is 11/30/2016, and today we're interested in talking about chronic total occlusions, which in the past, if patients were symptomatic and if needs be, it basically there was only one option, and that was bypass surgery. And so, and that was difficult having only one option, since everyone expects to be offered angioplasty and to be in the hospital overnight and go home. Nobody's expecting to stay on and get bypass surgery and be in the hospital for a week anymore. And so, and actually we've been able to avoid that on a lot of patients. Even with main left disease, we've been able to do angioplasty. So most of my patients have an expectation of less than cardiac surgery. I'm not a big advocate of bypass surgery myself, because I think overall it's in some ways playing Russian roulette, because we never know what the outcome is going to be. Yeah, sure, it's a controlled situation. Patients go into surgery. The surgery is done. They come out. But the problem is the post-op complications that are very frequent. And so about 40% of people have paroxysmal atrial fibrillation post-op, and so that becomes a struggle. Patients get volume overload because their system's not functioning exactly right, and so we have to sort of do the thinking for their kidneys. They've got a lot of antidiuretic hormone in circulation because they're taking painkillers. They've also had surgery. All those things result in decreased urine output, so then we have to start thinking for their kidneys, and we give them Lasix and so forth, and that's a problem with volume overload. We got to get them up and get them moving. That's hard sometimes. And then there are these unforeseeable complications like perioperative stroke, patients who have complications with have bleeding, and they have to go back to surgery again. And so all those things make surgery sort of a crapshoot. And so if we can do angioplasty with a much more controlled situation, we feel so much better about our patients. And so to have the option of opening a chronic total occlusion with angioplasty is a good thing. Well, it's hard to really kind of get that kind of work, even though everyone says that they offer it. To do a chronic total occlusion takes a lot of effort. Patient basically has to lie there on the table for usually several hours. The doctor doesn't get paid any more for doing that than he would doing a straightforward angioplasty. And so it's a commitment from the physician of 3 or 4 hours. It's a commitment from the patient of 3 or 4 hours, the team for 3 or 4 hours, ties up the room. Sometimes it's part of a hybrid procedure, which is even more expensive rooms that are $3.5 to $5 million rooms. That's tying up surgery as well. And so all this makes chronic total occlusion not so desirable for physicians. And so even though a lot of physicians say they offer it, they'll give up pretty readily and send the patient to surgery. And so Dr. Lombardi, who is at University of Washington in Seattle, is the foremost gentleman for doing that procedure, and he's totally committed. And so we've got someone out there this week who's going to have that done. We've sent a lot of patients to Dr. Heuser, who's in Phoenix, Arizona at St. Luke's, who has a strong commitment. He's got some of his own designed instruments that he uses with special catheters and special rotor-rooters. And so it's a whole different technique. Sometimes it's done antegrade, sometimes it's done retrograde, sometimes it's done antegrade and retrograde. Sometimes the coronary CT is useful. And so we thought we'd show you one of these and talk about it, and bring this out as being very important, and to have someone who has this repertoire available to take care of your patients certainly makes for greater patient satisfaction, and certainly decreases chances of somebody having to go to surgery. We also use Dr. Jabber, who is at Emory, and so we've had several people that he's done. We've got somebody that's going to be going there soon for a chronic total occlusion of a vessel and multiple vessel disease. So having somebody that does this readily is important. I think somebody at Trinity is taking it on to do more chronic total occlusions in our area. Tampa General purports to offer it, but I don't see a lot of chronic total occlusions done there. It was in their recent publication that they sent out for people to see what services they offer, and CTO is listed in there, but I don't think they have the volume. Dr. Stromquist at Bay Pines does a lot of chronic total occlusions, and he's had great results. He's only available for veterans. Let's see, Beth Torreo is here. Torres. Beth Torres is here. Hello, Beth. And so moving on, let's talk about a particular patient that we have. So we're going to present our case study. We're going to talk about coronary collaterals physiology. We're going to discuss CTOs, the frequency, the clinical importance, treatment, intervention options, current guidelines, the role of coronary CT, which, you know, I'd be interested in because of our experience here with CT, and then some case examples. So we'll start out with a patient here. And so we have a patient that had decreased exercise tolerance, and he was consulted for a second opinion for his coronary disease treatment. There are a lot of people that are very reluctant to go to bypass surgery, and then there are doctors like me that are very reluctant to send patients to bypass surgery because it's not a piece of cake. And so to have this option has been terrific for me. So here's a gentleman who's in his mid-50s. He has a history of peripheral arterial disease, hypertension, prior tobacco use. He's had hyperlipidemia. He presented after awakening with some rest angina, with a recent exertional angina during a job. He had a mild troponin elevation, the ER, no EKG changes, so he would be classified as a non-STEMI, depending upon the troponin elevation. Non-STEMI, acute coronary insufficiency. This would be considered basically one of the acute coronary syndromes. And so basically he had a cardiac cath that showed totally occluded circumflex, which is not uncommon, and I have a collection of those. And then there were attempts at crossing the short segment of the CTO. And if you're not a totally committed physician and that's not what you do all the time, and you're not a CTO specialist, just giving it a try is not going to be successful. A lot of doctors do this. I guess they can charge for it, but it's not going to be you don't just say, hey, I tried to cross it, couldn't do it, that's it. Because then you would attempt, after having not been able to do antegrade, then you would attempt retrograde. And then you get some of your special techniques out. So couldn't cross it, no further angina. Patient had fatigue, new exercise intolerance since then. He's on dual antiplatelet therapy, beta blocker, anti-lipid treatment. Use of beta blocker is, again, for angina, not for having acute cardiac events. Since he had just a little troponin, we don't know what the echo showed, how much injury he has or damage. Initial catheterization showed 100% occlusion of circumflex, collateraling the right, filling circumflex retrograde, inability to cross by someone in a cath lab, which doesn't mean that was a CTO specialist, so we don't know how to classify that. And here's a sample of what this looks like, and you can see the main left is short. The left anterior descending is a large vessel, there's septal perforators, and a diagonal vessel that's given off. Left anterior descending going down towards the apex. And let's look and see if we can see the retrograde filling. And so here's the filling injection of the right. And let's see what that shows. And apparently that showed some retrograde filling. I can't say I see a little bit. Maybe this is some of it right here. Can't tell unless it's shown dynamically. So then what do we do now? And so the prospect would be continued medical management. Other options would be stress test, functional evaluation. I'm not sure why we'd want to do that if he has exercise-induced chest discomfort, fatigue, poor exercise tolerance, and is unable to maintain his previous lifestyle. And then the attempt at PCI, and it's called an attempted PCI. And I don't really consider it an attempted PCI. I consider it addressing the chronic total occlusion. Tampa General cites an 80% chance of opening the vessel. Hopefully, perhaps that's keeping it open as well. That's in their recently published data. And Dr. William Lombardi, University of Washington, would quote a greater than 95% chance of opening a vessel and keeping it open. So, so the numbers there at Tampa General are not, would say would be attempting PCI, and Dr. Lombardi would say completing a PCI because of his numbers. And so clinical pathophysiology, it's not so simple as you might think it is. And so we've got anastomotic connections which are called coronary collaterals that are filling retrograde. The question is, can you demonstrate those vessels are present, and can you demonstrate that you can go retrograde and open the vessel by coming in both directions? And so that's part of the trick. And the coronary collaterals are anastomotic connections without an intervening capillary bed between portions of the same coronary arteries and are between different arteries. So that means if there's no capillary bed there, then it may be traversable, that you may be able to get a wire back across and then move back in that direction to retrograde approach the chronic total occlusion. My colleague Nick Koch has had a lot of experience with chronic total occlusion, and he's going to tell you about some of his experiences, and so he's coming on to continue this discussion. Hold on for a minute, please.
So hello guys, can everyone hear me?
Yes.
Okay. So you went through that initial case of the gentleman with the CTO, chronic total occlusion. So now the question is, what do we do about this? I wanted to kind of give a little overview of what is a CTO. Talk about, skip through some of these a little bit.
You got the engine.
Yeah, so I don't know if y'all saw the moving images here. Okay, let me go through. So here's his angio images of his initial cath, actually. So the initial one before he came to us, as we can see here, left main looks pretty good, but LED looks good. Here the circ is totally occluded here with no antegrade flow.
There's filling retrograde there, too.
Yeah, and then when we shoot the right, we definitely see collaterals filling back to the circ system here. So
can you go back on the other filling by collaterals from the LED? Yeah, there you go. Can you let it play?
Yeah. See if I can pause it here.
Yeah, there it is right there. Can you show them that? Yeah.
And some additional left-to-left collaterals here from the LED distribution to the circ. So I believe he already hit on some of the physiology stuff. So, coronary collaterals, it's a normal phenomenon, and this is kind of our body's way of potentially offering alternative sources of blood supply to an area that is deficient in blood supply. And kind of one of the key things is timely enlargement of these collaterals may avoid a transmural infarction or even death. That's why everyone's seen patients who come in with a total occlusion, never sought help, but they've got collaterals, and the heart function is relatively preserved. Back in the 50s, they demonstrated the presence of, at birth even, of corkscrew-shaped collaterals in even normal hearts. These are pretty small lumens, short lengths, but these were even seen in normal kind of heart specimens. In patients who had autopsy with coronary disease, that these number of collaterals and the size of collaterals was increased, that we'll mention. In the 60s, Fulton, he showed that clinically, the longer the history of angina, the larger the number of large caliber collaterals at autopsy. And that's kind of a physiological thing that happens. We'll talk about pruning, but these kind of smaller collaterals get pruned out, and you get left with a larger number of large caliber collaterals that improve blood flow to that region. In the 70s, we first demonstrated functional coronary measurements during bypass and during PCI. And it really wasn't until the early 2000s that the existence of functional collaterals in the absence of significant coronary disease was proved in a decent-sized population. And that's from kind of this study from 2003, where they took normal patients, they occluded a coronary artery, and they found that, even when they included a normal coronary artery, they had about 18% of the blood flow was due to collateral circulation. So again, there is some capacity at, normally in normal patients without coronary disease for collateral circulation. And that led to kind of here where patients without coronary disease, if we look at their collateral flow index, it's pretty low. But in patients with coronary disease, now you get these group of patients that are having, more significant collateral flow, as evidenced by, kind of this graph skewing over to the right here. So, an important thing is this process called pruning, where, normally we may have, a number of small 10 to 200 millimeter collateral vessels. As you get occlusive coronary artery disease, pruning occurs where you get growth in collateral vessels and decreasing in number of the small vessels. So in essence, you get an increase in the number of large collaterals here. And really that serves to increase flow to this side that's, obviously needs the blood flow. They've also looked at survival, so patients that have sufficient coronary flow reserve with sufficient collaterals over time presumably have a better survival than patients with insufficient coronary flow reserve. So how do these form, or what happens? So after you have a total occlusion, the post, after the stenosis, that post-stenotic pressure falls. Then this causes kind of a redistribution of blood through kind of some of these pre-existing arterioles from non-ischemic regions. This causes shear forces, increase in endothelial wall stress. You get these chemokines, growth factors that are secreted. And with days, you kind of get this inflammatory reaction and a lot of change in the matrix and proliferation of smooth muscle cells. So this whole cascade of, events occurs after an occlusion. And that causes, collateral growth through, either vasculogenesis, angiogenesis, or arteriogenesis. And really at the end you get, transformation of maybe pre-existing small collaterals into more functional muscular collateral arteries that, we may see on cath. Just some, factors that may improve collateral circulation. They've looked at studying some of these to see if they can improve outcomes, given patients colony stimulating factors, physical exercise, or even external counterpulsation. There's some observational studies, physical exercise, no randomized data, and just some small data about, trying to use these stimulating factors to improve collateral circulation. So what do these look like? So here's an example, of a proximal LAD, chronic total occlusion, where, even the LV gram, you still see that the wall function is pretty normal, preserved LV function. When they look at the right, this is before intervention, you see, a pretty substantial collaterals filling that LAD all the way up to kind of that proximal segment. After PCI, then we lose this filling. Now we have antegrade flow down the artery. So in this case, this patient had enough collateral circulation to preserve myocardial function, that anterior distribution. So what is a CTO? Kind of getting to the meat of this. These are chronic total occlusions or absent antegrade blood flow for about 3 months, according to most documents. After someone's been revascularized, this collateral circulation has been seen to decrease after about a day, and it can take about 6 months for all that collateral circulation to decrease now that if you've opened up the native artery. The degree of filling can predict, presence of a residual viable myocardium if they've had an old MI. How common are these? It's been estimated anywhere from 15 to 30%. Some patients say, or places say 20% of angiograms reveal evidence of a chronic total occlusion. And really there's a lack of really clear evidence on what to do about these. We'll talk about the current guidelines, but in general for the same artery, they kind of downgrade a chronic total occlusion compared to a severe stenosis in our current appropriate use guidelines. So they've really, up until, now and even still, CTOs and non-occlusive severe blockages are treated differently. That's due to a number of reasons that we'll talk about, but, symptoms are perceived as rare. It's perceived that, if it's already been occluded, that they're not symptomatic from it if they have collaterals, or that you can easily control them with meds. It's also believed that, if you revascularize that area, that you're primarily just revascularizing a infarcted myocardium that will not benefit from opening that artery, which may not be true. And so that's led to relatively low overall rates of revascularization of a CTO of about 35%, either via PCI or CABG. Patients who do have CTOs that are going for PCI, only about a third of these attempts are at the CTO artery. If patients are getting bypass surgery with multivessel disease, it's variable how often they'll try to bypass that CTO, anywhere from 69 to 89%. So the questions here are, A, should we revascularize, and B, how do we do that? We'll touch on some of the guidelines. This is the 2012 appropriate use guideline, which we're all familiar with now from just kind of the increased scrutiny of this. And kind of skip this one because I like this slide here, where for the same artery and the same non-invasive study findings, so say you have an intermediate risk stress test, patient with class 1 or 2 angina, certainly if you have a non-CT, if you have a severe blockage with angina intermediate risk test, it's certainly appropriate to open that artery. But for whatever reason, for the same classification of patients, it's a kind of an uncertain rating in appropriate use guidelines. And we can see that for the same artery with the same risk stratification on a stress test, the same patient, a CTO is downgraded compared to a similar non-CTO artery. The 2011 guidelines for intervention, they mentioned kind of a similar story where about a third of patients undergoing angiography have a presence of a CTO. They do mention, though, that stress-induced ischemia can be elicited in the majority of these patients despite collaterals, but only 8 to 15% of these undergo PCI. So again, we can start to see evidence that a lot of these patients can have inducible ischemia on whatever test we choose, but a minority of these actually undergo intervention. And so there's a lot of reasons that cause this, one of which that we don't know who's going to benefit, and some of these procedures can be complex. So the impact on long-term survival is relatively unsettled. Decision on how to intervene really requires individual approach, whether you're going to send them for percutaneous intervention or continue medical treatment or send for surgery depends on, of course, their other anatomy and kind of their wishes and their symptoms. There have been some studies that say patients who undergo revascularization of a CTO do fare better in symptoms and reduce the need for CABG and improve LV function. So currently it's a class 2A recommendation, so patients for PCI have a CTO with suitable anatomy and a operator with appropriate expertise in this. So these procedures are a little bit more complex, maybe a little bit more risky than a non-CTO intervention. So the risk of coronary perforation in general, PCI, is about 0.2%. And most of these are from probably interventions for CTO by wire perforation or kind of ablative devices during heavily calcified arteries. One registry of over 4,800 patients of undergoing CTO PCI, perforation was estimated at 0.9%. This is a review from 2009. Patients, going CTO PCI compared to those undergoing PCI of a non-CTO artery really had similar adverse outcomes, though dissection, was more frequent in the CTO group, 17% versus 13%. Another meta-analysis in 2011, overall success was about 77%, though some centers had as much higher. Again, similar kind of risks of adverse outcomes, 2.9% of coronary perforation, though some of that may determine, we'll mention the different approaches, this may be higher in a retrograde approach. So, again, there is some controversy on the risks of CTO PCI. We kind of touched on coronary perforation. But again, these procedures are sometimes longer, so these patients are exposed to more contrast, sometimes more radiation. And if you lose the collaterals, does that impact the patient as well? They do recommend that, because of the increased risk of perforation, GP2B3 inhibitors and direct thrombin inhibitors that have no antidote should not be used when attempting CTO until you have a wire safely into the distal lumen. as we'll see with some of these interventions, sometimes the wire goes subintimal, and you may not know if you're back in the true lumen distally, so you kind of want to avoid some of these agents. 2012, management of stable ischemic heart disease. Again, they quoted in there as, saying there's no current evidence that survival is improved after successful PCI of a chronic total occlusion. So this is kind of what our current guidelines say, despite some other evidence. Skip through some of this. So kind of one of the other questions is, do these patients have ischemia? Again, we mentioned the current guidelines kind of downgrade CTO intervention. And as we all know from our appropriate use guidelines, there's a lot of emphasis on ischemic burden. So we have to kind of prove that these patients, via some modality, have ischemia on some sort of non-invasive testing. There's also a misconception that, the CTOs already supply a completely infarcted myocardium that's not prone to ischemia. So in the Canadian CTO registry, only 17% of patients had reduced LV function with the CTO artery. So that alone kind of, tells us that, majority of these CTO cases don't, they haven't already had transmural infarction. If the majority of these patients already had normal LV function, only a third of these patients had EKG evidence of infarction. And even with extensive collaterals, they've shown resting ischemia based on FFR measurements seen in the vast majority of these patients. So even at rest, a lot of these patients, even with collaterals, have an abnormal FFR and evidence of ischemia. This was a study 2014 of 100 patients, CTOs and controls. All their CTO patients demonstrated an ischemic FFR. Even 78% of those patients had a resting abnormal FFR. So again, at least in this population, all these CTO patients had evidence of ischemia based on kind of current modalities with FFR. This is the 2001 study of patients with a single artery CTO, and they had a PET perfusion within 90 days. Most of these patients had reversible defects on PET. It was similar in patients with or without collaterals, so just the presence of collaterals didn't really help pick out who had ischemia and who didn't. In those that had single vessel CTO without myocardial infarction, stress-induced ischemia was always present. So, based on these results, this suggests that collateral circulation is really insufficient to prevent stress-induced ischemia. Though, as we've seen, it can preserve myocardial viability, it can help symptoms, but vast majority, or maybe even all these patients, do have abnormal blood flow, abnormal coronary reserve. Another study, 2008, they looked at MRIs in patients, and they looked at segmental wall thickening. And so really, if they had a transmural scar and they had a PCI to CTO, the segmental wall thickening was unchanged. However, if it was not transmural, less than 25% or 25 to 75%, they had a positive effect on the wall thickening and ejection fraction up to 3 years. This is a single center study from 2011. They looked at 300 patients that had a PCI to CTO. They had pre and post perfusion images, and they kind of came out with a baseline ischemic burden of about 12% was optimal to identify those who are likely to have significant improvement after PCI. So the average baseline ischemic burden was about 13%. This decreased to less than 70% after PCI. So we have some anecdotal evidence that maybe patients with a CTO don't have typical anginal symptoms. Maybe they're more likely to have atypical symptoms or shortness of breath. Our example patient that I had, he didn't have any further angina, but he just was a very active young guy. He exercised, worked out regularly, but he just never got back to his baseline status after even after a couple months. He just always had some exertional symptoms, but no typical anginal symptoms. There's some prospective evidence that there's improved quality of life measures with CTO revascularization with these patients. And kind of a review of 3 studies that compared CTO intervention and one that compared either surgical PCI to medical therapy. They saw less physical activity limitations, fewer anginal episodes, and greater treatment satisfaction with CTO revascularization. Obviously, at some level, patients are probably more satisfied that you're actually doing something for them as opposed to just leaving that artery blocked. So, certainly a mental, psychological component there. But, based on the other patients, measures, they, reported less physical limitations. 2014 study, multi-center study that, prospective, that looked at quality of life in 387 patients. And really, these medically treated patients had no improvement on the questionnaire. However, patients that had either, PCI or CABG for CTO, they had, again, improved physical outcomes, decreased anginal frequency, and just really a better improvement of their disease perception. And again, just a slide to illustrate that, patients who had single vessel disease, really the minority of these patients with CTOs undergo intervention. So, even patients with left main or three vessel disease that undergo CABG, the minority of these patients are having revascularization to a CTO. So still probably an entity that's being undertreated. Outcomes, we don't have any clear type A, good randomized data. We have a lot of observational perspective data though, including this meta-analysis of 23 studies that, suggested that PCI of CTO was associated with improved all-cause mortality and lower adverse outcomes. Another meta-analysis from 2010 found improved mortality and reduced need for CABG. But we have, we don't have robust data on, kind of hard endpoints as far as mortality in these patients. We do have some upcoming studies, stuff to keep an eye out if anyone's interested. Explore, Decision CTO, and Euro CTO are three, randomized studies that are, going to be looking at, it's really more randomized data for longer-term outcomes for revascularization. So, so if we decided that this patient has ischemia and we're going to intervene, how do we do that? First we've got to decide, is it feasible? A lot of times these are more difficult. These are obviously chronic occlusions, total occlusions. We don't have a channel to pass a wire through, so sometimes it's maybe blind. And there's some morphologic features. We'll also talk about the role of CT in that to, maybe predict, is this going to be one that's feasible to intervene on or not? Some of these features that we looked at is certainly the occlusion duration. If it's a very long, if it's been occluded for a long time, it's heavily calcified, that may be less feasible for intervention based on a shorter length occlusion. Do they have bridging collaterals that we can potentially use? Is it a shorter or longer length? And is there kind of like in the proximal cap, kind of a little nipple or a point that we can use to guide our wire? Historically, success has been kind of in the mid 70% range. Different specialized centers have, improved success rate. The European CTO Club reported 83%. There's been reports of dedicated operators with rates of, over 90%, more dedicated centers of CTO interventions. This is a 2003 study. They reported technical success, kind of a low to mid 70% range in hospital MACE adverse outcomes, about 5%. And what they looked at predictors of PCI failure, so, chronic occlusions of over 1.5 centimeters, if they had severe calcifications, a longer duration of occlusion, or those with multivessel disease were all predictors of PCI failure. So again, the optimal technique depends on a number of features that we'll talk about. There are, in general, a couple different techniques. There's an antegrade and a retrograde technique. So antegrade is really kind of going, kind of burrowing or pushing through that occlusion. So in our patient with that circ, taking a wire down the circ and trying to go antegrade, just, basically shoving different wires to try to find a channel through that chronic occlusions. And there's all sorts of different wires, different stiffnesses. There's different wire techniques to do this. There's also a retrograde technique where we make use of maybe these collateral channels. We go through a non-occluded artery, back up through a collateral channel, retrograde through that blockage. Ideal channels may take a subtle course. They may be larger collaterals, but sometimes, based on the anatomy of the collaterals, this may not be feasible. So that came out a few years ago with an algorithm to use for planning these. So a lot of times, as you saw in our patient, we do dual injection where, we may go in through both groins or wrist in the groin, so we can inject the left main and the RCA simultaneously to get a better visualization of these collaterals and the occlusion itself. So, after you do dual injection, you'll look at, do you have a proximal cap, and you'll make your decision on, if you're going retrograde, antegrade, and which kind of modality you're going to use. And they have specialized catheters that go subintimal and kind of re-enter the lumen. And again, just to point out, all these wires that we use, they all have different, tip flexibility. So, in general, the more stiff wires are more the kind of the dedicated CTO wires. But again, increased risk of perforation and subintimal entry out of the lumen. And so this recently studied or published this year was an algorithm from the Progress CTO trial of predicting the success of a CTO. So we looked at, again, some of these features that we saw. Is there a proximal cap, or is it ambiguous? Do we have absence of interventional collaterals? Is it a very tortuous vessel, or is there a circumflex CTO? And the higher, each of these is assigned a point, and the higher the score, the less chance of success of intervention of that CTO. As you can see here, sensitivity, specificity, as your score get higher, the chance of having a successful PCI decreased. So back to our case, so he underwent, again, high-risk PCI for a CTO, and he had a drug-eluting stent placed as circ. So here, an example of dual injection. So we have a catheter up his groin femoral artery, as well as a catheter up through his right radial artery, so it can inject the left main and the RCA simultaneously. And what we see here is when we do a simultaneous injection, we get filling of the collaterals, and we can get a better idea of, in this case, he had a fairly short segment CTO here that was pretty well defined. Another example, it's also important to maximize your view, because in the other view we foreshorten this occlusion, so we get a better look at the length here that we have to cross. So again here, in his case, we went antegrade. So, eventually different wires, antegrade, eventually found the true lumen again, and as we inject retrograde first, we want to make sure that we're still in the true lumen before we inject antegrade and risk kind of, perpetuating a dissection if we're subintimal. But here we see the wire in the lumen. And again, now that this is after some balloon inflations in the CTO segment. So now when we inject retrograde, we don't see as brisk collaterals here. We see filling antegrade now. Once we inject, we wait a little bit, then we inject antegrade, and we start seeing filling down that circumflex artery. So now that we've opened up antegrade flow, we lose some of that collateral circulation, as we saw in other cases. Kind of skip ahead. Now we have a stent delivered in the circumflex artery, and then kind of our final picture now. We got a large, kind of a couple large OM vessels, and we have an open circumflex. So this was a kind of another part to this I wanted to add in is, again, we kind of do a lot of focus on imaging here, and I wanted to look at the role of coronary CTA. This was actually published last year, a pretty good review of the role of coronary CT on revascularization of CTO. And it's a modality that lends itself well to this, because a lot of these factors that influence CTO success we see pretty well on CT. So we can see, we certainly see a lot of the calcification. We can see the vessel tortuosity, stump morphology, if there's multiple occlusions or lesion length. And sometimes we see this stuff better than we do on angiography. When we're looking at coronary arteries on a CT, typically, if we're looking at if we find a CTO on the coronary CT, typically the distal vessel is opacified with the CTO. This is not opacified with contrast on CTA. Acute occlusions, may exhibit a lot of positive remodeling, and CTA may have difficulty in differentiating high-grade stenosis subtotal occlusions from complete occlusions. If they're lesions that are longer, close to 1 centimeter or more, those are more likely complete occlusions as opposed to subtotal or high-grade occlusions. And there is kind of a sign reverse attenuation gradient that may be more specific for chronic total occlusions. So again, an example on coronary CTA correlated with cath here. We have kind of the right coronary artery. It's mid-segment here. It's completely occluded with non-calcified segment with no contrast opacification here, but you see contrast opacification in the distal RCA, and this is correlated with the cath images here showing a chronically occluded right. Again, an example of the problem of, on CTA, it looks like there's complete occlusion with loss of contrast here with distal filling. On cath, this turned out to be kind of a subtotal high-grade stenosis of the RCA here. This is a sign that may be more specific, reverse attenuation sign that was specific for CTO, but it's not sensitive. It wasn't seen in all CTOs, but if you have a patient, here's RCA again with a chronic occluded segment, but we have distal opacification of the artery here. Normally, in the vessel, the highest attenuation area, the highest Hounsfield unit will be the proximal vessel, then it decreases as you go along. But in this case, the Hounsfield units, the attenuation decreases as you get further along the vessel because you get more filling via collaterals in the distal segment. So this is what's called the reverse attenuation gradient. And one study found, this was a specific finding on CTA to identify a chronic occlusion. This is a patient with a subtotal occlusion with still a small channel. It looks like it's completely occluded on CTA, but you have normal attenuation gradient here that we'd expect with a normal artery. We'll skip through some of these. Again, one of the advantages of CTA may be we can see the distal vessel on CTA possibly better than we can on cath. So here's a patient with, on cath, they had a chronically occluded LAD. We see, we don't see the distal LAD vessel that well, so it's hard to see the course or the vessel itself, but on CTA, it lays out the LAD pretty well. And so that may aid in planning CTA revascularization, where we want to know what the rest of the vessel looks like. Is it tortuous? Is it calcified? And one issue that CTA can lay out for us well. Sometimes in cath, it's hard. We may miss a flush occlusion. So in this case, a patient that underwent angiography and they kind of missed the flush occlusion of the patient had an intermediate osteocclusion. But if we may have difficulty seeing that here as opposed to on CTA. We see this calcified segment and kind of the distal part of the vessel that we don't see in cath here as well. So we may find, flush occlusions of vessels that we may not see in angio. And again, they've looked at multiple studies on CTA. These are characteristics of the lesion on CTA that may predict PCI failure. So again, a lot of the common findings are heavily calcified cross-sectional area, longer length vessel in general, may not be as feasible or may predict PCI failure for CTO. There's also a score based on a lot of these CTA criteria that we can use. Again, a score greater than 3, very difficult case. It may predict failure. But again, highly tortuous vessels, severe calcifications, multiple occlusions, if they've already had a failed attempt, all these predict failure in a more difficult intervention. So just kind of a highlight of the role of CT. Again, we can identify CTA. We can use it for procedural planning. Even we talked about revascularization proving ischemia. CT, we can also use CT perfusion to look at scar and look at myocardial perfusion. Another interesting area is, some patients have places have looked at laying the CT data on top of the angio during the live pictures to kind of help them plan intervention. That kind of gives them a 3D roadmap to go down. We can use it for follow-up to look at the stent patency, and we can also use CT to identify lesions that may not be amenable to PCI. So we'll end with a few cases from Dr. Harrison's clinic here where we kind of made use of coronary CT. This is a 75-year-old patient with a history of intervention to a circumflex artery. Here's his 3D reconstructed coronary CT. We see the LAD here. We see the circumflex artery with a stent present, and we don't really see any antegrade filling down the artery there. And we looked at kind of the reformatted planar images. We see kind of the stent with no opacification and no distal vessel opacification with a occluded circumflex stent. Again, I believe this was a prior CT on him, showing, in this case, a patent vessel. Again, we have, a lot of these modalities we can make use. Perfusion Here we have MR, CT perfusion. So here both showing abnormal perfusion in this kind of infralateral posterior wall. Even on CT perfusion, we have evidence of scar. On late gadolinium enhancement, we see evidence of myocardial scar, probably about close to 50% on this lateral inferior posterior basal mid wall here. So again, just making use of non-invasive modalities, we kind of proved scar, proved evidence of ischemia, as well as proved evidence of kind of what the actual anatomic substrate, what the actual lesion is on CT. Again, other modalities, CT perfusion echo strain in this patient. Again, the circumflex vessel. He had a kind of a dense, large area of abnormality on CT perfusion that correlated pretty well with his abnormal strain on echo. Another patient, 67-year-old male. He had a cath in 2009 that had, that showed a chronically occluded right. He did have some diagonal disease that was medically managed at the time. He did well for several years. And then he presented with, again, recurrent chest pain. A repeat cath again showed a chronically occluded right, some diagonal disease with some reported left circumflex disease that, was not seen on review of his cath. But at that point, he was worked up for bypass with multivessel disease, and he kind of came for a second opinion as he didn't wish to undergo surgery. He underwent a CTA that showed, again, the chronically occluded right, a severe diagonal disease, and really only mild circumflex disease. So again, we looked at his right coronary artery here. Again, a lot of heavily diffusely diseased vessel where it's, likely chronically occluded in this mid segment where we see distal opacification down to the bifurcation. Again, another view of this, heavily diseased mid segment here, completely occluded with collaterals filling the distal portion of the vessel. Another patient, and then this patient's currently undergoing workup to have CTO, PCI elsewhere. Another patient, 75-year-old male with a right coronary artery CTO. He did have chest pain. He had a stress test. Again, he had a reversible inferior defect. Initial cath, he had, again, the presence of the CTO with left to right collaterals, and they were unsuccessful at attempting PCI. He then underwent CTO PCI with a dedicated operator, and he had 3 drug-eluting stents placed to the RCA. This happened to be his coronary CT 1 year prior. I don't have one showing the occlusion, but 1 year prior we have a right coronary artery with some non-calcified plaque here, and again with a more distally non-calcified plaque here. And I think on this cath report, it appears that this kind of more distal segment was likely the one that ruptured and occluded based on the report, but they stented approximately to distally with 3 stents. But again, we have kind of a 1 year prior of a coronary CT, even, maybe just illustrates a more vulnerable plaque that progressed or ruptured and eventually occluded. Another patient, 82-year-old male with chest pain, had a history of left circumflex occlusion, so he underwent coronary CTA. He had severe multivessel disease. He had moderate LED stenosis. He had an LED stent that appeared patent on the CTA. It was hard to tell. A severely diseased circumflex artery, and he had what appeared to be obstructive RCA disease. He eventually underwent cath and CTO PCI of the circumflex and obtuse marginal branch. So here's his LED with a kind of a stent in the mid segment that potentially appears patent with distal filling. He does have a calcified segment prior to the stent. There's left circumflex vessel here. Again, calcified segment with the area of total occlusion and what appears to be some distal filling of the vessel. Here's his cath films here. Again, LED that appears patent with the circumflex artery that's completely occluded here. This is pre-PCI. And again, with the placement of the stent, we now have a good filling of a decent-sized obtuse marginal branch. And this is his follow-up PCI, so again, another use of CTA to follow up these lesions to ensure stent patency. This is a CTI 1 year later showing a stent. Now we see opacification within the stent and distal vessel filling 1 year after his intervention. I think that maybe the last one, 61-year-old male with a history of chest pain and coronary disease. He had a diagnostic cath done a few years ago, 2012. He had a proximal subtotal occlusion of the LED with distal filling, totally occluded obtuse marginal branch, what they called a ramus that was chronically occluded, and a proximal CT of the right coronary artery. So, certainly significant findings with the chronically occluded right and a potentially subtotal occlusion of the left LED. He underwent CTI or CTO PCI with a drug-eluting stent to the right and PDA. And then a couple days later underwent PCI of the LED. So here's his kind of pre-procedure planning CTA, where his LED, you can see here, non-calcified plaque with distal vessel filling. So, maybe somewhat difficult on here to say, is it subtotally occluded, is it completely occluded based on the CTA. Right coronary artery, again, proximal segment. This just after that, there's an area that likely completely occluded with distal vessel filling. And here's his cath films pre his RCA, again, completely occluded with some collateral formation. Again, this is post-PCI. He had drug-eluting stents placed, and to his LED they read as a subtotal occlusion. We see this kind of small channel where the LED continues, and this is post-PCI where he had stents placed to the diag and LED here, as well as one to a obtuse marginal branch here that we don't see filling. So a few cases, a lot to go through, but kind of a general overview of chronic total occlusions, and specifically kind of wanted to add in, the role of coronary CT, its use of, planning and following up these patients. So any questions, comments?
Well, that's a nice presentation. Can you go back to the slide where you show the MPI and the CTO? There was a slide back there where you had the delayed late gadolinium enhancement from the MRI. It was yeah, that's good. And so we just wanted to show here that we frequently see patients that have congestive heart failure, and they have a chronic total occlusion of a vessel that's leading to one of these papillary muscles. And so you can see clearly in this view that there's an anterior lateral and posterior medial papillary muscle, and basically compromising one of these muscles can produce mitral regurgitation that can be intermittent. And so we have patients that frequently come with congestive heart failure, and their doctor has basically done everything that they can do, and everything they can do means that you've had previous bypass surgery, you've had some angioplasty and some stents, and now you have a chronic total occlusion that's causing ischemia to the papillary muscle, and we can't do anything about that because we don't do CTOs. But they don't tell that to the patient or refer them for a CTO. They just say that's all that can be done, and you go home and you sit in a chair upright to sleep at night. But if you have that done, certainly your family and your loved ones are concerned about you and want to get a second opinion. And so that's unfortunately that if you as a doctor don't want to see the patient go to another doctor, you've mandated that by your actions. It would be a lot easier if you just connect with somebody that can do a CTO and say, I can't do this, but somebody else can, and let me send you to somebody. Usually you wind up sending them out of town anyway, so you're not going to lose the patient. Many doctors are obsessed with not losing a patient to another doctor, so they don't do anything. And so then the patient comes to another doctor like me, and I'll see the patient, and what we'll be looking for, obviously, is we're looking for the papillary muscle dysfunction. So we collect a group of patients of chronic total occlusions of either a OM1 or a diagonal that goes to a papillary muscle, and we're actually looking for that, and we're using PET scans or whatever to show that there's viable myocardium in that area. Once we demonstrate that, then all we have to do is send the patient to a CTO specialist. And there's nothing magic about CTOs. They're guys that have dedicated their life to CTOs, and so you can just find one of those guys. They have, you can look them up in the patent registry, because usually they have several patents of several devices they've invented themselves that they're using. So they have more than just what normal person has. And then they've got this commitment that they're in the cath lab all day doing these 3-hour cases, which nobody else wants to do, because in the same time you can do 2 or 3 cases instead of just doing 1 case and getting paid the same. So you find a CTO specialist, identify that person, and so we've got Dr. Jabber up there at Emory, and then who's done several of those for us, and we have Dr. Heuser, who's in St. Luke's in Phoenix, and then William Lombardi, who's probably the best in the world, is at University of Washington, and that's where one of our patients is going this week to get his right coronary opened up. And so they all but guarantee that those vessels will be opened up. And so in my experience, the patients we've sent out, we've only had one mortality from a perforation. And that's what you would expect if they'd had bypass surgery, because again, there's some mortality associated with bypass surgery, the post-op complications, and so forth. So it works out pretty good. And so you can see in these particular patients here that there's late gadolinium enhancement, but it's only partial. And so that means that the rest of this myocardium is viable. It's just some endocardium that's been infarcted. And that looks like in this particular case less than 25, well, certainly less than 50%. Over here you can see this is probably a little area of infarct, but the rest of it looks pretty good. And so so you've got a lot of viable muscle that you can reperfuse that can give you better results and resolve congestive heart failure as an issue. And these patients, when you do that, become extremely dedicated patients, because you've taken them from, that's all you can have, there's nothing else to be done, you're going to sit in your chair at night and sleep every night short of breath, to now you can go anywhere, do anything, and you have these patients that are seemingly dedicated to that. And it would be very simple if your doctor just said, hey, that's all I can do, but there are other people that mastered chronic total occlusion, they can help you out. So that's just a lesson from that big group of patients that we have, since we're sort of a secondary referral center for second opinions. We got a large group of patients like that. Anything else from anybody else? Well, it's time to wrap it up. So thank you very much for attending today. We'll be posting this at cardiaccarecritique.com, where we post the recordings. And so I think that's a very nice presentation, Nick. Thank you very much for coming today. Bye-bye.